All right, so let's get started. What do we want to accomplish in the next 45, 50 minutes? Let me try to cover that for you. The first thing that we're going to do is try to answer the question, why are we still talking about ICD-10? That may be a question on your mind. That may be a question that some of your doctors have, or some people in your billing office. They say, you know, we did ICD-10 last year. Why are we still talking about that in 2016? I'm going to try to answer that question right off the bat so that we can make sure that you've got a good way to explain that. Then we'll take a look back at what happened in 2015. What went well with ICD-10, share some of the data with you, what went poorly in 2015, so that we can start to use that to take a look forward at what are the outlook for the next 9 months in 2016? What are some of the risks that we see for physician practices as they continue to roll out ICD-10? And then how to mitigate those risks. The two big risks that I've seen from different practices in our conversations thus far is, again, first and foremost, to physician productivity. And that's of paramount importance when you look at a lot of the national data, when you look at what doctors are frustrated with. It's that with all of the new initiatives, with all the government changes, it takes away their time from patient care. And that's ultimately, at the end of the day, all of our mission is to help take care of patients. If our doctors aren't taking care of patients, nobody is. And in our fee-for-service world, if our doctors aren't generating revenue, nobody is. You've got to make sure that you protect against that we don't turn our doctors into coders. We don't turn our doctors into coders. Now, you have to balance that with the real revenue cycle need that says you have to get your claims paid, and you have to code correctly to do that. And nobody was in the exam room except for the physician. So how do we balance those needs? We're going to talk about that, talk about where some of those ICD-10 risks are to those two areas. Again, I'll make sure that I leave time for questions and answers at the end. If you're just joining us, welcome. Feel free to put any questions that you may have in the questions panel, and I'll answer as many of those as I can. So I like to think of metaphors and analogies. That sometimes is helpful. One of the things that a lot of people compared ICD-10 to was Y2K. You remember this? A lot of people pointed to Y2K as the doomsday scenario, right? All the computers would forget what year it was. And a lot of people compared ICD-10 to that type of change, because ICD-10 was a one-day change. On September 30th, you had to use ICD-9. On October 1st, you had to use ICD-10. It was considered to be the Y2K of healthcare. And a lot of people point back to that as well, saying there was a lot of hype. There was a lot of lead up to ICD-10, but it really ended up being a non-event. And I think that's an unfair analogy. I don't think that considers all of the hard work and energy and effort that you put in to making your organization successful with ICD-10. And ICD-10 wasn't just a one-day event, right? ICD-10 isn't over. We're going to continue to use ICD-10 codes for a long, long time. I think a more appropriate analogy might be having a baby, right? You remember back to having your first child. This is my wife and my oldest son on the day that he was born, and you go through all of that time, all of the prenatal care, all of the 9 months, all of the baby showers leading up to that date, right? But on that day when your child is born, that's when all the hard work really begins. And that's the same thing with ICD-10. ICD-10 wasn't over on October 1st. ICD-10 began on October 1st, right? And the way that your organization uses that, the way that your organization has to think about that will change over time. As you get more experience, a lot is going to change, right? This picture is from 6 years ago. Here's what that looks like today, right? And sometimes it looks nice and neat, and sometimes it's a little crazy, right? ICD-10 is much more like birthing a child than it is to Y2K. That's why we're still talking about it. That's why it's important. And let me share some of the data with you that I think is helpful. You remember in the lead up to ICD-10, everybody was really worried about what was going to happen, right? You had consultants that were recommending getting a line of credit in place for 3 or 4 months of operating expenses so that you could cover salaries if the worst happened. Medicare predicted that denials would double or triple as a result of ICD-10. That was the prediction going forward, right? And then what happened? What happened was that denials didn't increase at all on a national level. Yes, there were certainly a few isolated pockets where certain payers had problems with some of their LCDs that was causing some denials, right? Some of you may have experienced that. But when you look at the data of what Medicare released, and this came out just a few weeks ago, they reported on data from the fourth quarter of 2015. And what Medicare said is, look at the top line. The total number of claims submitted is exactly the same as the historical baseline. The historical baseline being the data prior to October 1st. 4.6 million claims per day. That hasn't changed one bit. And then if you look at the bottom number, you'll see that total denials didn't change either. Maybe they went down by 0.1%, but I think that's statistically insignificant. So denials didn't increase. So the same organization, CMS, predicted that denials would double or triple as a result of ICD-10, and they're reporting on the data showing that it hasn't increased at all. And so the question that we have to ask is why? How can both of those things be true? Maybe it could be a possible explanation is that ICD-10 wasn't as hard as we expected. Was it all hype? Everybody was really concerned about it, and it was Chicken Little, it was Y2K? No, I don't think so. I think that does a disservice to all of the hard work and all of the changes that were put in by the payers, by the vendors, by the providers in order to successfully transition to ICD-10. So I don't think it's that ICD-10 was really a non-event. Another possible explanation is maybe the claims data is much more accurate, much better than what Medicare expected. Again, that's a plausible explanation, right? Maybe all of the providers across the country spent their weekends in 2015 memorizing all of the new ICD-10 codes. But again, I think that's probably an oversimplification. Maybe that's the explanation for certain organizations, for certain providers. But I don't think it can explain the phenomenon across the entire industry. I think the most likely explanation is that we haven't seen the full impact yet. We haven't seen the full impact yet. Yes, we started using ICD-10 on October 1st, and yes, we haven't seen an increase in denials in the fourth quarter. But I think that's ahead of us, not behind us, right? ICD-10 was not a one-day event. We're going to continue to use ICD-10 probably for the next 7 or 8 years at a bare minimum. So when we look back at 2015, you'll start to see how this happened. Let's look at the good news first. What happened in 2015? The good news is that we survived October 1st. There was no large-scale meltdown. Claims were processed, claims were paid, patient care didn't suffer, right? And a lot of people credit this to the CMS announcement that they said they would offer this 12-month grace period, right? They made this announcement in July that there would be a 12-month grace period where they would not deny claims due to lack of specificity. So that's the good news. What was the bad news of what happened in 2015? Well, it's actually the exact same thing. CMS delaying these denials delayed some of the consequences of ICD-10. It pushed it down the road. And what that means is that a lot of people who have poor workflows are being successful today, right? Now, I'm all for the grace period. I'm all for the extra time as long as you use it smartly. The problem is if you have a bad process and you don't know it. You're having these bad habits, but they're being reinforced because there are no negative consequences for that bad habit today. And that is a problem that's waiting to happen for a lot of practices. And to compound the problem is the fact that most people view ICD-10 as a Y2K type event. They were successful and they've moved on to other initiatives in their practice. Their leadership has taken their eye off the ball. They're not watching this anymore, which makes it a very difficult problem to anticipate and a very difficult problem to prevent. So let's dig a little bit deeper into the details of what happened. What did CMS do? There was a joint press release between the CMS and the American Medical Association. If you remember, the AMA was one of the most vocal enemies of ICD-10. They were instrumental in getting ICD-10 delayed. Their objective, their stated objective, was to make sure that ICD-10 actually never happened. They realized that that was not going to happen, so they fell back to this position with working with CMS to offer this 12-month grace period. And what it said was, as long as you are close, as long as you're within the right code family, which is the first 3 digits of ICD-10, they wouldn't delay, they would not deny the claim. They would not deny the claim, and they applied that to the PQRS and value-based modifier programs as well. Okay? Now, this was for Medicare only, and what we've seen thus far is a lot of the commercial payers have taken the same approach. They're not required to, but they've taken the same approach in their own financial best interest to make sure that the ICD-10 rollout was a smooth process. And any problems down the road would not necessarily be their fault, would not necessarily be their responsibility. Let me show you what I'm talking about. You remember, think back to Wednesday, September 30th. It was the night before ICD-10. There were a lot of nervous people. Everybody had made their plans. They made their list. They checked it twice, and they were waiting to see what would happen the next day. We watched the news and watched Twitter, and you saw a lot of vendor announcements coming from EHR vendors, practice management vendors on the first day, tweeting out photos from their war room saying, "We've been successful with ICD-10. Raise the victory banner." There was no national meltdown, right? It wasn't a bad day. Now, a lot of practices, a lot of hospitals said, that's great, but let's hold our horses just a little bit and see what happens. Let's make sure that we're able to submit claims and make sure that that transition happens correctly. And it did. You know, you wait a week, week and a half, and you're starting to see that the clearinghouses are able to accept the data. The payers are able to accept the new claim data, right? All of the information is flowing smoothly. And this is where you started to see press releases from clearinghouses, from the insurance carriers, right? A lot of them stood up at MGMA and said, we have successfully transitioned to ICD-10. And again, a lot of administrators, a lot of revenue cycle managers were saying, let's wait and see what happens once those claims are adjudicated. Let's make sure that we get paid, right? Because the proof is in the pudding. And again, after about 30 days, going through that cycle, going through that process, a lot of practices felt comfortable that they had been successful with ICD-10. The claims were getting paid. They didn't see a spike in their denials, right? And everybody kind of takes a deep breath, a sigh of relief that the worst scenario didn't happen. And that's certainly something to celebrate. This means that all the data is flowing smoothly, the claims adjudication process is working, but there's still a big question mark that says, yes, the data is flowing from the provider to the payer and the claims are getting paid, but what is the quality of the data? Are we coding as accurately as we need to in order to get claims paid? For today, the answer is yes. But there's still a question mark that says, when the payers begin to crack down, when they begin to enforce some of the policies that they have not enforced yet, how will the organization fare then? You see, the way that this process has been set up, everybody else, all the other stakeholders have said, we're good. Our system works. And if there's a problem downstream, the problem is with the provider, not with the payer. The problem's with the provider, not with the vendor. And that's where the risk is going forward. Now, you remember, again, think back with me in the lead up to ICD-10, a lot of people like to talk about some of the specific crazy new codes available in ICD-10. Remember, there are 69,000 codes in ICD-10 compared to only 16,000 in ICD-9. And the ones that got the most attention were some of the crazy codes, right? This was probably the most popular code that people like to poke fun of, this flaming water skis encounter. Now, we looked at, over the fourth quarter, almost 10 million coded diagnoses across different clients across the country. We never saw a client use this code. It doesn't happen. It got a lot of attention, but nobody uses it, right? There are a lot of codes out there that nobody uses, that nobody pays attention to. These aren't the ones that are going to cause you problems in the future. The codes that are going to cause you problems are the unspecified codes. Unspecified codes existed in ICD-9, and unspecified codes exist in ICD-10. There are actually more of them in ICD-10 than there were in ICD-9. Now, there was not a lot of risk to using an unspecified code in ICD-9, right? For the most part, claim would still get paid. It didn't really cause a problem. And in ICD-10, that's not necessarily true. There are two risks associated with using unspecified codes in ICD-10. There's a short-term risk, and there's a long-term risk. And I'll talk through both of those with you. First, the short-term risk. The short-term risk is something you'll probably see over the next 6 months in your practice if you've not started to see this already. And that is that the claims are going to get denied. You may see this with certain payers. It'll probably get phased in. The payers will do it at different times and do it in different ways. But when you zoom out and think about it, why is the payer going to deny an unspecified code? Well, think back to the beginning. Why did the payers advocate for the migration to ICD-10? Why did they want to lobby Congress to continue moving forward with ICD-10? Why did they spend millions of dollars to rewrite their adjudication processes to handle ICD-10? And the answer is, it's the data. They want the more specific diagnosis data. They want that detailed information on their insured patient populations. And if the provider community does not give them that data, they are going to start denying claims. We've heard from some carriers that they plan to start that in April. I've heard others say June. Medicare obviously said they would not do it before October, right? We've seen some carriers, probably just a handful across the country, who have already started to do this. And when they crack down, what that means is your AR days will stretch out, and you will have billers and coders going back to the clinicians, going back to the note to ask for more detailed information. And that takes time away from the revenue cycle staff. It takes time away from the provider to stop and answer those types of questions. And that's what we have to be careful about. That's the short-term risk. And it may not happen all at once, right? You're probably not going to see all of your payers start to deny all of your unspecified codes at the same time. I'll give you one example of where we've seen this already. Georgia Medicaid has started to deny for unspecified codes. And they've taken a pretty aggressive approach where they are denying any unspecified code. And the problem with that is there are times when it's appropriate to use an unspecified code. There are times when we don't know, or there is not a code for the particular condition that this patient has. You need to know what codes you're using so that you can fight back against the payers, so that you can use more specific codes when you need to, and so that you can push back against the payer when you're using an unspecified code appropriately. That's the short-term risk to using unspecified codes in ICD-10. Now, what's the long-term risk? Because I mentioned that as well. The long-term risk, and from a timing perspective, it's a bit trickier to gauge, but we're moving away from the fee-for-service world, right? We're moving towards a value-based reimbursement, outcomes-based reimbursement. Some of you may already be doing this in some of your Medicare Advantage plans. Some of you may be a part of an ACO. And what happens in that world, it is all about patient acuity. It is all about the expected outcome for that particular patient compared to the actual outcome for that particular patient. And the way that we're seeing payers do this, handle that risk-based adjustment, is based on the patient's diagnoses. That's, again, another reason for the shift to ICD-10 is to be able to be more detailed, to be more granular in the patient acuity. And if you're not coding as specifically as possible, you risk flat or declining reimbursement in that world because you're not accurately showing how sick your patients are, right? The same rules apply, right? If you didn't code it, it didn't happen. And you can't code it if you don't document it. But a lot of times what we see is the documentation from the provider is good. The documentation from the provider is specific. The problem is they're using a lot of unspecified codes. They're using it as a catch-all. They're using it as a cheat sheet. They're using them because they always use them in ICD-9, and it never caused them any problems, right? And that's why you have to think a little bit differently, right? Remember going back to the beginning. Do you remember before you had your first child? There were lots of things that you thought you'd never do as a parent, right? And then having that baby changed your life. You'd never be the same. You did things differently because you had to. You did things differently because as you start to learn how to be a parent, you have to make adjustments. And we have to do the same thing with ICD-10. We're requiring new level of detail now that's very, very different than what we've been doing before. And we have to make sure we are preventing some of these risks, that we're protecting our organization and thinking ahead rather than reacting once we start to see these denied claims. So a lot of people ask me, well, how frequently does this happen? How often do people use unspecified codes? And we're still early, right? We've only been using ICD-10 for 5 months now, but we've tried to collect some data. And like I mentioned before, we reviewed about 10 million coded diagnoses in the 4th quarter. And here's what we saw. We saw across the country the average use of unspecified codes was just over 30%. Just over 30% of the coded diagnoses were considered unspecified, right? Now, again, some of those are less specific than others, and I'll give you some examples of those, okay? But that was what we saw as the national average. Now, when we looked across our client base, and we saw that was closer to 10%. Now, a lot of our clients are larger practices. There's some sample bias there because they are organizations who are focused on this and who are trying to drive that number down. But we saw most people coming in just over 10% in our client base. But the real question is, all of that is interesting for comparison's sake, but what you really need to know is what is your unspecified rate, and that may differ from one provider to the next, right? You may have some doctors who do that very, very well. You may have some doctors who do that very, very poorly. It will differ by specialty, and you're probably never going to drive that down to 0, right? There are times when you should use unspecified codes, but a lot of the most commonly used unspecified codes really shouldn't be used, and they will cause denials in the near future. Let me give you a couple of examples because I think it's helpful to see this. So what we saw, one of the most commonly used unspecified codes was this one, M19.90, right? And you look up the description, it's unspecified osteoarthritis of an unspecified site. Right? Now the problem is, if you go look this up in the code book, what you'll see is there are 95 other ICD-10 codes that are more specific. Right? And this unspecified code was being used about 11% of the time. Right? So if there was an even distribution, you'd expect each code to be used just over 1% of the time, but this one was being used 11% of the time. Right, so it's a high use code. It's one of those that might stick out if a payer were trying to look at the data and starting to deny the unspecified codes that were most commonly used by their providers. This might be one of them. And you'd see that the reason is it's unspecified as far as the type of osteoarthritis, meaning is it primary, is it secondary, is it post-traumatic osteoarthritis? But it's also unspecified as far as the joint. Is this in the knees? Is it in the hip? Is it the ankle? Is it the shoulder, the elbow? And unspecified as far as the laterality. Right? So we can be more specific here. So if it's osteoarthritis of the knee, which knee is it? There are only 2 knees. Don't use a code that says unspecified knee. We don't know which knee the patient was complaining about today. You can see why the payers want to know this information. You can see why they're going to deny it if you don't give it to them. All right, let me give you another example. Another one that we saw quite frequently was a malignant neoplasm of an unspecified site of the female breast, C50.919. Again, a total of 54 ICD-10 codes in the code book for the malignant neoplasm of the breast. And unspecified codes were used over half of the time. Right? High frequency usage of these unspecified codes, and it's not telling me, again, site or laterality. Is it upper inner, upper outer, lower inner, lower outer? Which side, left, right, bilateral? Okay. Another example, saw this a lot in primary care, otitis media. H66.90, unspecified as far as the type of unspecified as far as the type of otitis media and which ear. You can see there are a lot of other choices. The unspecified codes were being used very, very frequently, and we're not being specific. Is it chronic? Is it acute? Right? Serous, non-serous. Which ear are we talking about? Payers want to know this data. Many of them are not requiring it yet. And what that means is, unless you're really looking down at the details, you're not seeing this problem yet. You're missing it. The process that you have in place today, however it's structured, data is flowing from the doctor to the billing team and eventually out the door from your billing system to your clearinghouse and to your payer. That process works today until the payers start to crack down. And when they crack down, right, because we know that's coming, but when they crack down, your process will have this feedback loop required between the billing staff and the clinical staff to say, I need more information here. Can you tell me more about the type of osteoarthritis? Can you tell me which joint? Can you tell me which side of the body? I need more data. And it's going to take the clinical team time to read that request, to research that request, and respond to that request. right? And that's the issue. That's where we lose our billing productivity. That's where we lose our physician productivity as a result of ICD-10. So you see, a lot of the concerns that people had about ICD-10 are still ahead of us. They're not behind us. And I don't want people to have a false sense of security that October 1st is in the rearview mirror. We don't have to worry about that anymore, right? All of the hard parts of being a parent happen after your child is born. Let me share a couple of quick studies with you that were done that I think might be helpful, trying to anticipate what the costs are for an organization to transition to ICD-10. This study was done by Nachemson Advisors. Many of you probably saw it published in the years leading up to ICD-10. And they split this out into pre-implementation cost and post-implementation cost. And then small practice, medium practice, large practice. Small was 3 providers, medium practice was 10 providers, and a large practice was 100. So let's look at that middle column for a medium practice. You can see the pre-implementation costs, those are all behind us. You've done your training, you've done your software upgrades, you've done your testing, that's all behind us. Now the post-implementation costs, the risk of productivity loss, the risk of payment disruption, for most people, those have not happened yet. And you can see those are the larger expenses. Those are the ones that you can do something about. Those are the ones that you can help prevent or make sure that your practice is on the low end of that range rather than on the high end of that range. The productivity loss, when you lose that time, you can never get it back. You can never get it back. And the longer it takes for you to improve your process, right, the longer it takes for you to respond once you start to see these types of problems, the larger your productivity loss will be. The payment disruption is the study's authors, again, asked Medicare, what do you expect to happen to denial rates? They said they expect them to double or triple. The more prepared you can be to make sure you're submitting good quality data so that your claims get paid, the lower you'll be on this spectrum as well. That's what we want to do. We want to be prepared because this is an area where an ounce of prevention is much, much better than a pound of cure. All right, another study that was done that I think is helpful to look at. The advisory board does some very, very good consulting work. They looked at Canada's transition to ICD-10 and said, where are the areas of cost, where are the areas of productivity loss as a result of ICD-10? And look what they put front and center. What they put front and center is a physician productivity loss of 10 to 20%. If you want to get underneath those numbers and understand what was happening is you had coders going back to the doctors saying, I need you to be more specific. Tell me more about the type of otitis media. Was it chronic or acute? Okay. Serous or non-serous? Okay. Was it in the left ear or the right ear, or was it in both? You know, that back and forth was taking up to 45 to 90 minutes per doctor per day to answer those types of coding questions. And that may be fine in Canada. That may be okay where most doctors are government employees. But that doesn't work in the United States. Our doctors are overworked already. They don't have 45 to 90 minutes per day to spend answering coding questions. Even if you cut it in half, they don't have 20 to 45 minutes to answer those types of questions each day. And in a fee-for-service world, it's just unacceptable. They cannot see fewer patients. And I think it is terribly unfair to expect the doctors to answer these types of questions at the end of the day rather than spending time with their families or with their hobbies or anything else that they'd rather be doing. Most doctors, view coding as a necessary evil. That's not why they got into medicine. And we want to try to protect them from that as best we can. Now, it's not just the doctors. It will take additional time from coding employees, from billing employees as well, right? You see that on the far left. You'll see they lose a lot of productivity in the beginning when they're getting up that learning curve, and we're still going through that, right? You'll see that will get worse before it gets better as the payers start to require more detail, but it will get better. Eventually, the long-term projected productivity losses for coding and billing staff is closer to 5 to 10%, even though it does get worse in the beginning. And that's not their fault, right? It's simply that ICD-10 is more detailed than ICD-9. It is more difficult and requires more time. And then if you look on the far right, again, you see that rework productivity loss. Basically, that ties back to the denial rate increase in questions, denials, inquiries back from the payers. Right? That's where you'll see that rework productivity loss as well. So most of this risk is still ahead of us, right? And how do you, a question that I often get is, okay, so how do you tie your unspecified rate, the frequency with which you use unspecified codes, to these types of productivity losses? And let me try to do that. Let me try to walk you through that thought process, that math of, so how do you get here? How do you tie those two numbers together? So what we did was assume, again, for a 10 provider practice, that each provider is seeing 30 patients per day, right? And on average, each patient encounter has 3 diagnosis codes, okay? So if you have 10 doctors, 30 patients a day, that's 300 patient encounters. 3 diagnosis codes per encounter is a total of 900 diagnoses per day. A 10% unspecified rate means you could have 90 denials per day for a 10 provider practice. Now, that's probably not going to all happen at the same time, right? Your payers are not going to all flip the switch and start denying 100% of unspecified codes all at the same time. If they did, there'd be no way for you to miss that, right? A 10 provider group would certainly recognize 90 new denials overnight, right? That's all, we talked about that. There's only 300 patient encounters, but 90 denials, right? And the reason for that is, that's a very high denial rate, right? That's a 30% denial rate. That's probably a tripling of what their denial rate is today if they're in line with national averages. But it's probably going to be more difficult than that to detect. Again, they're not going to do this all at the same time. Blue Cross may start in April. Aetna may start in June. Medicare may not do it till December. Right? This is why you need to know how at risk your practice is. For that group, that 10 provider group with a 10% unspecified rate, right? If that was distributed equally amongst their providers, that would be 9 denials per doctor per day. If those produced questions back to the doctor and it took 3 minutes to answer each of those questions, that's 27 minutes per doctor per day. You can see how easily you can get into that range of what was seen in Canada, into that problem of 45 to 90 minutes per doctor per day if you were in the 20 to 30% range. And then the cash flow at risk, if you use the medical economics figure of $25 is the cost, to resubmit a denied claim for a 10-provider practice, the cash flow risk is close to $2,000 per day if you had a 10% unspecified rate. So when we try to tie those two together, you can see how quickly that can be a real problem. So the questions for 2016 that we need to think about as you think about how ICD-10 is going to evolve, what you really need to know is, number one, how at risk is my practice? All right, you got to know your numbers first. Know the data. How at risk are we? What is our unspecified rate? Right? Where are our problems? Because once you know that, then you can start to decide what you're going to do about it. How do we make this process better? How do we get more specific? Where do we need to be more specific? And how do I change my process to make sure that I get the right code the first time? And this is the key part, without turning my doctors into coders, right? I could put a lot of new requirements on our physicians, but I've got to be able to do that in a way that doesn't put more work on their plate, that doesn't slow them down, that doesn't make them the coder. All right, so first, how at risk is my practice? Then, how do we use that to change our processes? What I would recommend doing, if you haven't done this already, is know what your unspecified rate is. We've been running this analysis for our clients. I'm happy to do this for anyone on the webinar who would like us to do this with their data. But we crunch the numbers and we can show you, okay, here's what your unspecified rate is. Here's how it compares to the national average, right? It gives you a lot of information that you can use to share with your team, to share with your providers, to examine where some of the potential problems for your organization might be. Our clients love getting this information. Most of them already know which of their doctors are doing this better than others. But I would certainly recommend doing this. Again, for anyone who attends one of our webinars, we'll do this as a free service. We're not going to charge you for it. We will crunch the data and send it back to you so that you can see what the unspecified rate is for your practice and what it is for each of your providers. And you can have some benchmarking data that you can compare that to. The other thing that comes with that is a review of your top 10 most frequently used unspecified codes, so that you can see what those codes are, so that you can see how many times they were used over that period. And you can see what the more specific ICD-10 codes are that you should be using. Okay, so that you can do a little bit of education, so that we can say, you know what, we should never be using pain in an unspecified shoulder. It was either the left shoulder or the right shoulder. Right? How can we make sure that we get that done correctly the very first time? Same thing with otitis media. How come, you know, there are 54 choices. Here's what they are. How do we get that done correctly? How do we make that easy for our doctors? So you've got to know the data first. If you know what your unspecified rate is today, I'm always interested to hear from people. Just let me know if you want to just type it into the questions section. That'd be great. Because if you're doing really, really well, I'd love to hear from you about how you're doing that. If you don't know what your unspecified rate is, again, you can let me know that in the questions panel. If you'd like us to do this analysis, just make a comment to that effect in the questions panel, and I'll have somebody reach out to you to get your diagnosis frequency information so that we can run that analysis for you. Just use the questions panel for that either way, and I'll make sure that we follow up correctly with you on that. Part of this, what it really makes a difference is okay, you know, how do we collect this data? When you're trying to look at where do my unspecified codes come from, right? A lot of it is how you're capturing the information, right? A lot of people, what they do is they go through, you know, some sort of code search process. Let me show you just one example that came from a client. What they were doing is they were doing a code search. They'd search for something like osteoarthritis. And when they searched for osteoarthritis, they'd see all of these 97 results. But the problem was all of the unspecified codes are in there, some of which they should never use, right? They couldn't take them out of their database, and their doctors would choose them. The other thing that made it really difficult was the codes that they would most commonly use were way down their list. Right? The most commonly used osteoarthritis codes are for the knee. So we think those should be up at the very top of the list. It matters how you display this information so that your doctors can quickly choose the right option. One way that another client handled this was an electronic super bill, and when they would click on osteoarthritis, it would give them the choices, sorted out by joint, so that they could very quickly see what the choices were. And they could make that selection with one click to say it was primary osteoarthritis of the right knee. Okay? There's a lot that you can do to make this easy for your doctors, but the very first thing that you need to know is how at risk is your practice, which unspecified codes are you using most frequently, and then you can start to think about how do we make sure we get the right code the first time? How do we do that without turning my doctors into a coder? How do I protect my practice from the physician productivity risk and the revenue cycle risk that come with using those unspecified ICD-10 codes? All right, now I know I went through that quickly. I've talked about a lot of different things, but let me do one last thing, one quick summary, and then I'll try to answer any questions that have come in as quickly as I can. I want you to here's some things that I think would be helpful to take away. Remember that ICD-10 started on October 1st. It wasn't over on October 1st, right? ICD-10 began on October 1st. That's when ICD-10 was born, right? And just like raising a child, you're going to have to continue to make changes. You're going to have to adapt and adjust. So you need to continue to make changes to your ICD-10 strategy. Right? That was not a one-day event, set it and forget it. You need to know what your unspecified rate is. And I think that's one of the key risk factors for 2016 and beyond is what codes are you going to start seeing denied, and then how does that impact from a long-term perspective the shift to value-based reimbursement. You need to know what those codes are, which ones you're using most frequently. And then you can figure out how do you change or adapt your current processes to protect your doctor's time. How do we change and adapt our current processes to make sure we get the right code the first time so that the claim gets paid completely and correctly the first time, rather than chasing that down on the back end. Okay, I hope that that's given you something to think about. I'll put my contact information up there in case anybody has questions or wants to connect on that afterwards. Again, before I open it up to questions, if you've got any feedback for me, what you loved about the webinar, what you hated about the webinar, put that in the questions panel. That's always helpful for me going forward. Right? If you've got any information requests, you'd like a link to the recorded version of the webinar, or you'd like a copy of the slides, you can let me know that in the questions panel as well, and I'll make sure that we get that information to you. So thank you again for your time. I hope that this has been helpful for you.